Welcome. It is Wednesday. I was trying to figure out what day it was. Wednesday. Oh, it's Thursday? Thursday, February 19th. I'll take Wednesday. It's the extra day. First, I apologize for the tardiness. And if you recall, it was a week or so ago, somewhere along those lines, that we had some great testimony on insurance coverage for prosthetic and orthotic devices, of which the committee really wanted to hear more. So first we have in Ledge Council, because we've never done a walkthrough of bill that's been on our wall. And so we're going to have a walkthrough of that. And then we have some testimony from Blue Cross.
Great. Thank you. Good afternoon. Jen Carby from the Office of Legislative Counsel. Put the bill up here. This is H432. This is an act relating to health insurance coverage for prosthetic and orthotic devices. One thing I will flag from the beginning is that this bill was introduced in 2025. So some of the dates, if you move forward with this, would need to be pushed out a year. So this bill amends an existing provision in Title 8 in the health insurance chapter on what is currently called, I believe, prosthetic parity, although this may also need to be updated. I think that all of the numbering has changed and maybe some of the language as I look at it since we did S30 last year that we wrote. So a lot of changes would need to be made, but this is coverage for prosthetic and orthotic devices and starts out with some definition language. It amends the definition of prosthetic device to add orthotic devices, so prosthetic and orthotic devices. And the current definition is an artificial limb device to replace in whole or in part an arm or a leg. This would change that to say it means leg, arm, back, and neck braces and artificial legs, arms, and eyes, whether standard or custom made. So this is expanding the scope of what we're talking about when we're talking about prosthetic devices and adding in orthotic devices. This would require, under existing law, health insurance plans must provide coverage for prosthetic devices in all plans, at least equivalent to that provided by the federal Medicare program. This expands on that a bit by adding, again, orthotics and specifying some particular sections of federal Medicare statutes and regulations. You find a typo in one of these when I was going through and sort of reviewing what they are, but these are pretty comprehensive Medicare coverage and payment provisions around prosthetics and orthotics. And then it specifies that coverage should be provided for a number of things. So under current law, coverage may be limited to the prosthetic device that is the most appropriate model that is medically necessary to meet the patient's medical needs. This would change that to say coverage shall be provided for all of the following. First, a prosthetic, and then adding or orthotic device that is determined by the covered individual's treating healthcare provider, that part's not necessarily different, to be the most appropriate model that, and then the standard changes from medically necessary to meet the patient's medical needs to adequately meets the covered individual's medical needs. And then it adds a new covered requirement for a prosthetic or orthotic device determined by the covered individual's treating healthcare provider to be the most appropriate model that meets the covered individual's medical needs for purposes of performing physical activities, such as running, biking, swimming, and strength training as applicable, and maximizes the covered individual's whole body health and the functions of their lower or upper limbs or both. Also requires coverage for a prosthetic or orthotic device determined by the treating healthcare provider to be the most appropriate model that meets the covered individual's medical needs for purposes of showering or bathing. Specifically requires that all materials and components necessary for the individual's use of the prostheses and orthoses described in subdivisions 1 through 3. Instruction on using the device or devices, materials, and components described in subdivisions 1 through 4. And the medically necessary repair or replacement of a prosthetic or medical orthotic device, material, or component, and more detail to come. It directs health insurance plans to consider coverage for prosthetic and orthotic devices to be habilitative or rehabilitative benefits for purposes of federal and state requirements around coverage of essential health benefits. It says for purposes of the coverage around the activity specific and the bathing and showering, prosthetic or orthotic devices, a health plan may require the covered individual's treating provider to determine that the additional prosthetic or orthotic device is necessary to enable the person to engage in physical activities. And then it gives examples such as running, biking, swimming, strength training, showering, and bathing as applicable, and to maximize their whole body health and the functions of their lower or upper limbs or both. It requires health plans to make their utilization review determinations in a non-discriminatory manner and cannot deny coverage for a prosthetic or orthotic device solely on the basis of a covered individual's actual or perceived disability. It also prohibits a health insurance plan from denying coverage for a prosthetic or orthotic device for a physical activity for a covered individual with limb loss or absence if the plan would provide coverage for an individual without a disability who was seeking a medical or surgical intervention to restore or maintain their ability to perform the same physical activity. And it requires health insurance plans to include language describing those rights under subdivisions 3 and 4 in the plan's evidence of coverage and any benefit denial letters. And some changes are just a little bit sort of cleanup or updating language. So any dispute between, and we're just changing from the terms insured and carrier to covered individual and health insurance plan. So any dispute would continue to be subject to independent external review. This keeps the language that allows a health insurance plan to require prior authorization for prosthetic devices in the same manner and to the same extent as prior authorizations required for any other covered benefit, just clarifying under the plan. Subsection E requires the plan to ensure access to medically necessary clinical care and prosthetic and orthotic devices and technology from not fewer than 2 different prosthetic and orthotic providers who are located in the state and are in the plan's network. And then it talks about what to do if those providers are not available. So in the event that medically necessary covered prosthetic and orthotic devices are not available from an in-network provider in the state, then the plan has to provide processes for referring someone to an out-of-network provider, fully reimbursing the out-of-network provider at a mutually agreed upon rate, less the covered individual's in-network cost sharing. There is existing language requiring plans to provide coverage for what under current law is medically necessary repair or replacement. This changes that to coverage for replacement of a prosthetic or orthotic device or replacement of any part of it without regard to continuous use or useful lifetime restrictions. If the covered individual's treating healthcare provider determines that the provision of a replacement device or part is necessary because of, and there's a list, a change in the individual's physiological condition, an irreparable change in the condition of the device or part of the device, or the condition of the device or part of it requires repairs and the cost would equal more than 60% of the cost of a replacement device or the part being replaced. It also allows a plan to require confirmation from the treating healthcare provider if the prosthetic or orthotic device or part being replaced is less than 3 years old. The last 2 are just updating some language. So the first keeps language saying that the health insurance plan cannot impose any annual or lifetime maximum on coverage. It expands that to prosthetic and orthotic devices, but is less than what applies to all terms and services under the plan. Some of this language may not even exist in our current statute because of federal changes. And then the change in what is now subsection F or becomes subsection F is just changing a may not to a shall not. It doesn't have a substantive difference. I just think it's clearer to say shall not. Otherwise, it sounds like may or may not. Section 2 directs a report on insurance claims for prosthetic and orthotic devices. So again, remembering that this was in the 2025 bill. So from last year's bill, it says on or before July 1st, 2029, each health insurer that is subject to an annual reporting requirement under a different statute, which is really sort of the bigger insurers with at least 2,000 covered lives in the state for major medical health insurance or issue plans in the exchange, would also report to the Department of Financial Regulation regarding the insurer's experience with this expanded coverage for prosthetic and orthotic devices. for plan years, and this had for plan years 2026, 27, and 28. So you'd want to move those out if you were going forward with the bill. And the report would be in a form as required by the Commissioner of Financial Regulation and include the number of claims for the goods and services required by the statute in each of the plan years and the total amount of claims paid in the state for those goods and services in each of those plan years. So basically, what did this end up costing? And then by December 1st, 2029, the Commissioner of DFR would provide a report with aggregated data for all health insurers by plan year to committees of jurisdiction, including this committee. Section 3 is the effective date. So again, from last year's bill, would have taken effect on January 1st of this year and rolled out over the course of the year as on the date that an insurer offers issues to use a health insurance plan, but in no event later than 1 year after. And the remaining sections will take effect on passage. And I do always have to flag when we talk about a health insurance benefit mandate that to the extent these are services not currently covered by plans in the exchange, there is the potential for a state cost, with the state having to defray any additional premium attributable to this benefit in the qualified health plans. That is the federal requirement. And I don't know if those would be seen as the expansion of an existing mandate or a new mandate.
Can you say that again?
Yeah, good, sure.
It's been a long time since we've done something like this.
We have not forgotten mandates. There's what's called a state defrayal requirement. And under the Affordable Care Act, for any new health insurance benefit mandate that is added, that a state adds after 2012, which is when things kind of got frozen in place, the state is on the hook to pay any additional premium amounts for qualified health plans that are attributable to that new benefit mandate. So if it costs X amount to add a benefit to a plan, then the state would be on the hook to pick up that amount for individuals, and any person covered under the plan, if it is deemed to be a new benefit mandate.
State pay additional premiums by creating a new mandate. All right?
Yes, yeah, that's attributable to the new mandate. It's state defrayal. You can look it up, or we can talk more about it, or have Annie in to talk about defrayal.
So I see.
And if there's curiosity about what the cost would be, that is an actuarial
Yes, oh, that's
question that is not,
got
maybe your insurers can do it, but
not for you.
it's not for me and it's not for JFO. I just want to be clear that
Yeah.
Nolan does many wonderful things, but he's not an actuary.
Yes. I'm wondering, because it's existing, that it's covered that they have to cover a device
Right,
that's medically necessary.
right.
So even the fact that we would essentially be changing devices that treat the whole.
I am flagging for you the
Yeah.
fact that this may be an issue. I cannot give you a definitive answer on whether this triggers state defrayal. I think we haven't talked about a mandate in a long time, and people just need to be aware that there is that additional element.
Alan.
Well, so that's what people with insurance, if they don't, state would pick up the difference. Okay, so what about no insurance?
This doesn't apply. If you have no insurance, you
So-
still have to pay out of pocket for whatever services
So
you're getting.
basically, you're saying this bill is only with people with insurance?
Yes, this is a health insurance
Okay,
provision.
so if Medicaid would be not involved in any manner of paying?
So Medicaid is a separate program. It is not affected by this
It would not.
statute, but you can hear from Medicaid about their coverage of prosthetic and orthotic devices if there's interest in that.
That is great, because it leads me into my next question. If you can expound on that a little bit. So we're not affecting Medicaid in this.
That's right.
We're not telling Medicaid that they have to cover all of this.
Well, this one, so I should be clear. This definition uses the definition that was in the statute, which did include Medicaid.
Okay,
But under the way we have kind of decoupled things in the existing, in the new statute, I'd have to look to see whether Medicaid is pulled in here or not. typically the state has decided whether Medicaid is in or out for a particular coverage requirement. So, so yes, this language, as written, this language does, stand corrected, include Medicaid in the definition of health insurance plan. We tried to be a little bit clearer going forward about not rolling Medicaid into the definition of health insurance plan, because that's, they're regulated and governed differently.
But wouldn't there be some liability there if you did one and not the other two?
No.
No.
I don't believe so. I mean, there are different programs. We have different benefits in Medicaid and in what's required in private insurance.
Leslie,
This may not be for you, but I don't know if there's a definition of whole body health. Like, what does that mean?
That's a great question. I believe in some model language, so maybe others who can speak to that.
Because in previous testimony, we had talked about people walking on the beach and showering, but showering was including, but not the beach. I was just thinking about our previous testimony. Could that qualify for a second or prosthetic? But I'll ask someone else. Can you also help me understand is the difference or what it means to be habilitative or rehabilitative?
These are terms from the Affordable Care Act. So, and I don't know if DFR can speak to that or if you need me to look it up. All right, I might have to look it up.
not a
So if I can easily give you an answer from something that I
And it could be later.
seems, well, all right, here we go. Here's something from New York State. So let's see what they find. All right, so rehabilitation services, this is from something that they adapted from a federal regulation and the National Association of Insurance Commissioners glossary of health insurance and medical terms. Rehabilitation services. Rehabilitation refers to healthcare services that help a person keep, restore, or improve skills and functioning for daily living and skills related to communication that have been lost or impaired because a person was sick, injured, or disabled. These services include physical therapy, occupational therapy, speech language pathology, and psychiatric rehabilitation services in a variety of inpatient and or outpatient settings. Habilitation services refer to healthcare services that help a person acquire, keep, or improve partially or fully and at different points in life skills related to communication and activities of daily living. They address the competencies and abilities needed for optimal functioning and interaction with their environments. Examples include therapy for a child who isn't walking or talking at the expected age. Adults, particularly those with intellectual disabilities or disorders such as cerebral palsy, can also benefit from habilitative services. They include physical therapy, occupational therapy, speech language pathology, audiology, and other services for people with disabilities in a variety of inpatient and or outpatient settings. I'm not sure how helpful that is, but some of
No, I
it
could see the distinction
Yes.
totally. Thank you.
is, and both, believe both habilitative and rehabilitative services were in the list of 10 essential health benefit categories that were in the Affordable Care Act. And that's where they sort of came into the more common parlance. Habilitative.
It's really a question about language, but I'm not sure you would be the best person to explain that. I
Put
can add
it out there and then others
I'm gonna
can
put
be
it
on
out there,
notice.
but I do know that we have someone on Zoom with us that had been in here before. I'm wondering what the difference between prosthetic and orthotic is in terms of.
We'll happily look on that, but I can look into it. If there is not someone who can get you that answer, I can get you that answer, but I can't.
We're adding, essentially, it was prosthetic. And we're adding in orthotics to all of this language.
Yes, and expanding the definition, of what constitutes prosthetic and orthotic devices beyond just arm and leg.
Yes. And I'm
I'm
wondering.
happy to answer a little bit if you want, just to touch on it. I mean, essentially, the difference between this is David Heiler from the So Everybody Can Move initiative. And
David.
it is, the difference is basically a prosthetic is to provide a limb where there is none, and orthotic is something that can help you if your limb is severely damaged or disabled.
Okay. Oh, and just to be clear, a prosthetic and a limb is, we're basically just talking arms and legs, or are we talking about like toes, fingers, hands?
You mentioned eyes.
It's,
Y-
would that be
Yes,
considered a limb?
anything that replaces a missing part would be considered a prosthetic, and anything that sort of helps to enhance a damaged or injured part would be an orthotic. I mean, people use orthotics on their knees to brace their knees. That would be considered an orthotic.
Okay,
And
go ahead.
how does that, how do you explain with the eyes? Give me some scenarios where that would be under this plan.
Are you asking me, or is that
Uh,
directed
whoever.
to me?
Go
Whoever,
ahead, David, because
That's a great question. I'm assuming that if you needed an eye replaced, that would be considered a prosthetic eye. So that would be considered a prosthetic. And again, I would imagine that in your insurance coverage, that would be already something that would be covered. I don't know. Can you hear me?
Yep,
Any
thank you.
additional eye parts that would be needed and required, but that would be considered a prosthetic as well.
question?
No.
Oh, sorry, I thought you'd had a question. Yeah, Wendy.
It kind of changes the flavor of the whole thing. Like I initially I was like the prosthetic device was for a replacement of one that was already that you already had, like an enhanced one. Orthotic, I would assume, would be the same thing. If somebody has a false eye, which would probably be covered under insurance for the first time around, they're looking for a second one. I mean, I guess I just don't understand how the orthotics fits into this bill.
Yeah, I think I'm a little confused. I think that's why are there examples of orthotics that you would need different orthotics for different activities?
So my associate from the national organization has just joined, Kyle, and if it's all right with you guys, I'm going to have him. I'm going to defer to him on that one.
Yeah, I'm gonna let legislative council go. We'll ask you this one last question, and then we'll go to Blue Cross Blue Shield, and then we'll come back to you probably with more questions. Hi, Kyle. Thanks for joining us.
Hi, Representatives, hi, members of the committee. To give you some examples, so an orthosis is a device that's needed to stabilize a part of the body that often has a mobility impairment. So the bill is required for custom orthosis. I think there's often a confusion of an orthosis where it's your off-the-shelf like shoe insert. These are very customized devices that brace the feet for them to allow for the mobility. So what happens is a lot of times the daily orthosis is in a stagnant position. And for them to be physically active, it's customized to the patient. So the clinician actually fabricates it and designs it for that patient to either cycle, for them to run, and they often have special hinges, but they're all custom made by the certified orthotist that is trained, that has a master's level degree. So these aren't your off-the-shelf devices. And so that's where you see the utilization rate is a lot lower, because the physician needs to prescribe it, and then the clinician then needs to determine the exact style of that device for them to achieve the health goal and the physical activity intended. So you often see these customized for cycling, you see them for running, or you see them possibly for strength training. But if the participant is doing all three of those activities, that orthosis can often do all three of those. So they'll only need that one additional orthotic for physical activity.
Thank you. That's helpful. Alan, well, wait a minute. Let's go to Blue Cross, and then we'll keep them here, and we'll ask
Okay,
questions.
well, this might help with Blue Cross Blue Shield with this question. Okay, so say a teen missing a limb, and at this time he wants to swim. So he gets his insurance to pay for a waterproof prosthetic limb, and then decides, in 6 months, he's grown out of that. So he can apply for another one to replace that. And then and I'm being devil's advocate here. And then all of a sudden he decides, I want to be a jogger. And that's a different limb of some sort. So is the insurance company going to be required to purchase all these, to have these guys, because it says for each individual to have a whole body health. So how many possibilities is there going to be here?
I think those are great questions.
Sorry.
I'm gonna ask that we hold that,
Okay.
because that's a great question. Like, so we'll make sure that we take additional, if we decide to move forward with this. I really wanted to get, Blue Cross in because we were all sort of, and I'm thinking, well, how much is this? So Courtney, if you want to come up, and thank you so much, Kyle and David, for being here. I hope you stick around because I think we're gonna have some more questions.
Hi, thanks for having us. For the record, Courtney Harness, Blue Cross and Blue Shield of Vermont. I'll start by saying we actually spoke with David and Kyle last week for about an hour, mostly so we could understand more about the bill, the proposed legislation, and kind of their goal and vision. It was really nice to be informed by people that frankly live this every day. Kyle and I have some mutual friends in the Paralympic space, which is unexpected. But all that to say, there's a lot of stuff in this bill that frankly we want to support. And we were pretty open with David and Kyle last week in saying this particular session represents some pretty specific financial challenges. And I'm happy that Jen invoked the issue with the essential health benefit mandate. So I didn't have to, honestly. But I think as we went through discussion, and first there's three parts of the bill that we've talked about or that Jen walked us through. The first one was what's medically necessary that everyone gets. And so that's what we do anyway for anyone that files a claim. The second one around physical activity, I think was specific to Rep. DeMar's question around who gets what and how often and how many. And then the last piece was showering and bathing. And David gave us some really helpful sightline into his own experience and without a waterproof prosthetic, what might happen if you decide, for example, if it's a leg, what might happen if you decide you want to go in a shower and try to balance. Given our current cost of care in the system, it's actually more expensive just for an ambulance ride than it would be for us to pay for the prosthetic. And so I think that's important for the committee to know. On the third component around showering and bathing, we actually see that as a preventative component of this bill that more than likely, speculation, more than likely has the opportunity to save money over time. As to the second part around physical activity, I think we fundamentally agree with everything in the bill from the perspective of every person, every Vermonter that we cover or not, should have the opportunity to participate in whatever physical activity they want, however they want to do it. We actually don't have the data and as far as how many members of ours would qualify and then want any of these items. And so what I'll do today is kind of give you all a range of how much some of the prosthetics cost, so that you have sightline into the potential costs, either to Blue Cross or to the state in this case.
Do you have, I know you don't have, it would be nearly impossible to come up with the numbers of how many people who would want to take advantage, how many orthotics or how many prosthetics or orthotic they would want. But do you have a figure right now of just how many members you have currently that have a prosthetic?
I can tell you the number of claims over the last 7 years. So it's 223 total claims in the last 7 years, and that covers full prosthetic devices and repairs. So that's what we have processed and approved. In those 7 years, there's only been 3 that we've denied.
200?
223.
223, but those are not necessarily individual members, they're both repair
Total
and
claims.
total claims.
Yep,
223 over
123, 7 years.
7 years.
Yeah. So now I'll try to dig in on that to say none of those are for physical activity beyond what's medically necessary, right? So that's 223, what I would consider to be in the first of the three components of this proposed legislation. So folks looking to get a device for everyday medical necessity. That said, and I would love if David and Kyle and their team could get some more data for Vermonters around who might be eligible, how many people would take advantage. That might give us more sightline into total cost. But for the devices that we have and codes that we have for devices, they range, and again, I'm just talking for the physical activity, they range anywhere from about $40,000 to $110,000. So, I think Rep. DeMar has already done a good job of playing devil's advocate, but, when we get up into that price range, and I just want to be really open and honest with this, with the committee, we would love to give everyone 10 of these. The reality of it is when we get into the six-figure range, potentially multiple per person, without knowing the magnitude, we end up in a position to think about premium increases. And that, like, we are really, really trying with every ounce of our existence to not do that. And it's not a particularly fun place to sit in today to say, like, hey, it just might be really expensive this year. We did share that with David and Kyle and say, like, this happens to be a not typical financial.
I will say that this committee is also
Yeah,
committed, has been committed to
agreed. Yeah, thank you.
doing this. I see Brian has a question and Tupper, but can I ask you really quickly? How much would, you said that you see, like the waterproof
Yeah.
or shower or bathing? How much would those be? Because you
less.
said you saw it.
Yeah, if I remember correctly, so I'm going back, and so don't use this as a quote, but more of a guide. I think there was around 20 claims on that particular piece, and I think the average of all of them was about 15,000. So that's over 7 years, and that was the average. So, and again, those are ballparks. I think depending on the person, it could be less or more in their medical needs and the process to go through, but I think that's a good average.
Per device.
Yeah, I think Chair Black was asking specifically on the showering and bathing.
So that was 15,000 per device.
Yeah.
Waterproof device.
This is really.
I have Brian and then Tupper and then Karen.
Yeah, I'm wondering how hard it would be to get a range of options to look at, because maybe we can't do everything at once, but maybe we take a step forward. Like, for example, I'm just throwing this out there as an example. I'm not saying this is what I would do yet, but like everyone can have two, one regular one and one special. And then we see how that goes, so that if someone can, even though it's not ideal, someone could say, I'm going to choose the one that I can go in the water with, so I can take a shower or go in the river or what have you. Or someone else might say, I'm fine taking showers without my prosthesis or my orthotic device, so I'm going to get the running one, but like, just if there was a way to kind of estimate giving someone their basic model and their like special one or whatever you want to call it, their extra, the advanced, the specialized, maybe that's the way, your basic and your specialized tool, or I don't know. I'm just wondering if there's a way to get a closer estimate, because if we were talking about everyone's premium going up 2 cents, like someone who testified said 5 cents. I don't know who said that.
Yeah.
I think that was from, I would say we would leave that language up to the committee in terms of what you want to decide. I would say on a state specific basis, and again, this is up to you all. We've had a lot of conversation about this internally. I mean, I don't say it lightly when I say, like, this is really something that we feel compelled to try our best at. the Kelly Brush Foundation, I think, my opinion, would be a great organization to have come in to talk about Vermont as a whole in terms of what some of those numbers might be. It's work that they do every day across a lot of these different areas. From the perspective of like maybe only doing one, that I wouldn't have a recommendation.
Yeah, I guess what I was getting at is not recommendation, but the cost. Like if we knew that it's giving everyone access to one, even if every single person who could possibly be in the Blue Cross Blue Shield system got a 6-figure one as their one, that the cost per person was $0.01 per person, that's something I would support. I'd be like, if everyone is paying 1 penny more so that 30 people can have this thing, maybe it's worth it. But like without any numbers, it's hard to know. Whereas if you were like, the premiums are going to go up 25% if you do this, that's significant, you know?
What I can commit to is trying to get that number, like, and for us, right? So how much of the 200,000-ish Vermonters that we cover, how many or what percent? And again, it's a little tricky in terms of what we're allowed to share and not, but like, I can try to get you.
Like, for example, like you said, even if it was like, we estimate that 100 to 300 of our members would be eligible for this service. And the maximum, the minimum it would cost and maximum for an additional thing would be 10,000 to 700,000.
Okay.
And then we can look at that and we can calculate, oh, if we give everyone the 700,000, one out of the 30 people, it's going to cost this much or that much. And then if you can't translate it into a premium, I think that's okay. But I think it would give us some scale or some idea of like the magnitude of the expense. That would just be helpful.
We could do that.
My question was a simple one. The orthotics that given you data 223, they're not in there, are they? No. So it's just prosthetic.
Karen?
Yeah, my follow-up was simple too. If you had the one that was waterproof, shower worthy, is that also like ocean swimming worthy? Is that a similar?
That's probably a better question for David and Kyle. I wouldn't be able to answer that.
And so just to follow up, if there's 223 claimants over 7 years, that's about 32 people a year. So even assuming 32 people a year would choose to have a second one. I don't know if there's a way to run that.
Well, I think part of, and again, I don't want to talk my way into saying, but we did have this conversation with David and Kyle, and so I'm going to mention it because I think what they said to us was really important. It's not like we don't anticipate that this would create a tidal wave of claims where it would go from 30 to 300. We don't anticipate that. And frankly, and this came from David and Kyle, like access to an appointment and the length of time that it takes to go through this process would just by default kind of limit it. So I'll say that. But as far as the specifics of what it limits it to, I wouldn't be able to tell you.
I have Alan.
Okay, and I might be wrong, but when we first talked about this, I think I remembered a figure of like 3,000 people.
I think that was the estimate of people in Vermont who are missing.
A limb.
I don't think it was missing a limb. I think it was an amputation.
Yeah, it could be fingers.
I think the total is 9,000. So the total that I remember from conversation with So Everybody Can Move is 9,000 Vermonters. And I'll again say that doesn't mean 9,000 Vermonters are all going to qualify for any of the specific pieces of the legislation. So when I say it's hard for us to give an estimate because all we have is historic claims data, it's hard for us to really say, here's what we might see.
And I guess my other concern is too, we're talking about the MVP and Blue Cross. I think the other thing is we mentioned here a minute ago that we might have to kick in some of the premiums for this. And the other thing is I want to make sure how Medicaid is involved in this, because that is kind of an insurance plan. And so that would concern me.
we would absolutely have Medicaid in to discuss the issues around having coverage for Medicaid, because I think there are special concerns with them in regards to federal and CMS. Leslie?
Very quick, I just didn't hear you. Did you say it was between 40 and 210,000 per device?
110.
Okay,
Yeah.
thank you.
Yeah.
Wendy?
I would assume that if somebody is going to ask for a second one, that they're gonna have to come up with a reason, like you're not gonna give a running limb to somebody who is never gonna run, like, so it would have to be some sort of letter to the insurance company.
Well, this is my understanding again from talking with David and Kyle. You're exactly right. So you take that 9,000 and then you back into if this legislation moves forward, essentially we don't have the ability to deny any of the claims. And again, this is my understanding of the process. If I am looking for a running blade, I go to a clinician and they say, well, you actually wouldn't be able to run even if you got a running blade, so we're not going to recommend it. That happens.
Mhm.
The other thing that happens is they go, yeah, absolutely. Here you go. And so to Kyle's point, and this was a really good piece of the conversation that we had with them, the level of training that the clinicians are at brings them to be the folks that say, Courtney's going to be able to run or not. And if not, then we're not going to recommend that you go through the process. And that goes with all of the activities, skiing, swimming, biking, whatever it may be. And so as I read it with this bill, we would be taken out of that equation, which for the daily device, we are anyway. So I think to leave that in a clinician's hand, from my perspective, is perfectly acceptable.
And I have a second question on this, as far as limitations, like, I don't see where we included any kind of limitations as to if you get a second one, that you can get a third one and a fourth one. I don't see any, like, we need to have.
Alan,
Okay.
I think you had a question, and I do want to acknowledge that Kyle, who's with us on Zoom, wanted to weigh in on something, and then if Courtney doesn't mind.
This is just a quick one. You know, the figure you gave us 40,000 to 110,000. Is that cost included with physical therapy and everything goes along with the new limb?
Yeah, and Kyle might be able to speak to this, but again, my understanding is that that's the whole process. So that's the initial visit through the creation of the device, through the fitting and that includes the whole process. Everything's wrapped up in it. Yeah, that's a good question.
Kyle, did you wanna?
Yeah, absolutely.
some
I just want to
input?
I would love to give just some thank you to Courtney to start off. I think as legislators, it's important for you to hear. I work with insurance companies all across the country as we're navigating this process. And I want to say I've been the most impressed I've ever experienced with the leaders of Blue Cross Blue Shield of Vermont. The level of compassion that they've showed for us. No, Courtney, I think it's important to say that as an advocate with a lived experience, as me living with the disability alongside David, it is really special to sit across from the insurer that has often denied you access to these things and saying, let's work together. Let's figure this out. And so I just want to start off with that. So let's kind of go through just some data. So the number you hear 40 to 100,000, that is often for the daily device for an above knee amputee. The physical activity device, Maryland is the one that did the cost study on this as well. The average cost of a activity specific prosthesis or orthosis is $11,250. So that 40,000, I'm an above knee amputee. I'm just going to show you my knee for a second. This guy, for walking, that is 40 to 100,000, but that's already covered. That's my daily device. So for an activity specific device doesn't have the technology that a walking leg does. And so that's where you see that cost of 11,250. The percentage that actually will access this. So the medical necessity, I want to make note on this. The insurers still have the process of utilization review. That is really important to us. The physician and the clinician have to be able to create their case to the health plan of why does the person need to access physical activity? Are they willing to access physical activity? And are they going to be able to safely use the device? So the physician and the clinician have to basically create a case to the health plan to say, this is why they need it, this is how they're going to use it, and this is the right device for them. And then the health plan says, okay, you've created your case, this is approved. We have had in some states where they have created limitations, and I think this is an opportunity for us to discuss that. We've seen for physical activity, often individuals receive one device for daily, one device for physical activity, and not everyone uses a showering device. And then the key thing about physical activity is only about 15% will medically qualify to access the physical activity device. So where we get that number from is a couple of things. They have to be willing and able. They also have to be able to safely use the device. And so the clinicians have to be able to justify that they're at a level. So there's a term called K levels. And so when a person with limb loss or limb difference gets diagnosed or has their injury, the physician will give them a level of ability. And in order to access a physical activity device, they have to be a level called a K level 3 or 4. It goes 0, 1, 2, 3, 4. The individuals that can access these devices are K level 3 and 4. That means they can safely ambulate. They can safely use it. And you hear that number of 9,000. 9,000 is comprised of you're missing a toe, you're missing maybe a finger. But if you think about the numbers of actual amputees, as you notice that claim number that Courtney used, that is a little bit more realistic. About 233 individuals will be the ones that actually utilize a prosthesis. What we see is about 30% of the entire disability community from limb loss and limb difference actually use a prosthesis or orthosis. They use a device, only 30%. And so you break down that number, and that's how we get to that 10 to 15% of utilization are the ones that would access a physical activity device. The other thing to note about the showering and bathing device, not everyone's going to need it. I don't need a showering device. I feel that I'm fine. I have a handrail in my shower. I use it. And so I think when you look at these numbers, again, the physician has to prescribe it, and they have to be willing and able to use it. I just wanted to make sure you all got that clarity, that information as well.
May I ask some very ignorant questions? I'm sorry.
Please, that's fine. No, it's okay. This is why we have this conversation.
This is obviously a subject matter I know nothing about.
Yeah.
So first of all, we heard testimony from some individuals who were frustrated because they couldn't go swimming in the river with their friends. I'm not sure why anyone wants to swim in the Winooski, but
Leave that aside.
and is there a device for swimming, or is there just a waterproof device, which would be sort of the same device that you would use shower or bathing?
The latter. So often those devices can be used for both. So for example, the swimming, often the ones that use it for like let's say I'm swimming in lap pools. The ones that often use that would be like a below knee amputee, because they'll put a fin on it. And that is honestly, that connects to the terminal, that connects to the socket. The socket is what's customized to the human body. And what's nice about these activity devices for a lot of the below knee amputees, you can swap them out, but that terminal socket stays the same. The piece that's fabricated to the body, and it allows them to switch out. Let's say you have a running foot or you have a fin for swimming, that often, but thinking about that example of the river or the example of the beach, you'll need a waterproof walking device. That could be, sorry, the emojis. Wow. We're trying to celebrate already. That can be used for showering, and that can also be used for their lake or the beach. It can be used for both.
And I keep you're describing this, and I'm just like thinking about interchangeable parts.
Yep.
So we heard, and to Alan's question, which is what I was thinking about. I was thinking about my son would switch sports like every year. Is there a different, we heard from some witnesses who were talking about playing hockey.
Yeah.
And lacrosse and
Mhm.
is each sport sort of like an individualized transformer
No.
part that you play?
That's a great question. So the devices are multi-purposed. A lot of times your physical activity device, like a running blade, can be used for multiple sports. Or let's say the device for snowboarding is often very similar for strength training because of how the componentry is designed. You often see a lot of these devices are used for multiple purposes. I will say, to give you an example, we've recently did a limitation in my home state, New Mexico, because we also added wheelchair coverage this year. We did a limitation of no more than 3 devices per missing limb. And then for the physical activity, it was at 3 years. If the person's physical activity goals and health goals have changed, the health plans can consider a new device. So let's say, we're also trying to be reasonable within limitation. Let's say in 3 years, like thinking about you're describing your son and your child, I apologize. Let's say in 3 years, they switch from a device that was for running, and they're opting to switch to more snowboarding because those two would be slightly different. They would consider now the opportunity to switch to a new device for their physical activity goals. But I think that it is reasonable for us to discuss limitations. I think our goal is to give people with limb loss and limb difference the opportunity to access an option of physical activity.
David, did you want to weigh in on that? On my ignorant questions, and again, I apologize for the naivete.
Yeah, no problem. I just wanted to add in too that there was a question about, the different prosthetics and I purchased my own running blade at one point, and it was a total of $2,000, which, it's not the state of the art one, but I think even the state of the art one is about 15,000. That, again, as Kyle mentioned, does not include a socket, but I can switch that out. I also, I received a grant for a snowboarding leg, which I can use for paddle boarding, or I can use it in the water. I can walk into the ocean with it, because I know that was a big question. A lot of these prosthetics are not ocean approved, even if they're waterproof, but you can, that one in particular, I can use for multiple purposes. So just wanted to add that in.
Really getting an education here. Leslie, did you have a question?
Thank you. I'm curious, there is a provision in here regarding prior authorization.
Mhm.
So I'm wondering what the role of prior PAs would be in here.
It's really interesting because that came up in conversation about Act 111 prior authorizations. And I think the way that we get around that is what Kyle mentioned in the process, which is it comes to us anyway.
I'm not sure.
So like as
DME was exempted from Act
correct.
111.
So in the process, when the clinician makes the determination, then it comes to us for approval. Because what we said in conversation with David and Kyle as well, if you didn't know, we don't have a prior auth in Vermont on certain things, and it is exempted.
Okay, so even though it's in here, it's exempted.
Yeah.
Just
No, DME is exempted. So
DME.
yeah, it's still, that language is good. There's still a prior authorization process.
Oh, exempted from not getting prior.
Correct.
Oh, sorry,
Yeah,
I
yeah.
got my double negatives.
Yeah.
Thank you.
Kyle, did you want to?
Yeah, and because I think one of the representatives made a comment about the total billing. So when you think about prosthetics or orthotics, that cost of that 20,000, that's the entirety of care. So unfortunately, prosthetists and orthotists can't bill for every visit like a physician does. So every time you go into the clinic and you see your doctor, they can bill the insurance company every single time. With prosthetics or orthotics, it is billed by device. So the entirety of care that exists, so every time I go in to see my prosthetist to get it fixed, to get it adjusted, to get it fabricated, to get the alignment, the entirety process of before and after receiving the device is built into that singular device. When you hear that number and it sounds like a lot, that's the entirety of care. And the reason why Yeah, global bundle payment. Thank you. Yeah. And the reason why we are fans of prior authorizations for a couple of reasons. So thinking about a small practitioner office, $15,000 is a lot. And unfortunately, let's say there's a situation where they go through the process to purchase that device and they start the process of fabricating the socket and all the cost comes out to that 15,000. And the insurance company comes back and says, you didn't prove your medical necessity and it's now denied. They're on the hook for that 15,000. And so they go through the process to ensure that the plans will cover it, will pay for it. And so then they can then start the process of providing that care and so that they can make sure that it's going to be covered and paid for.
Can I ask a follow-up?
Yes.
So Blue Cross Blue Shield has people who would be expert in dealing with these kinds of devices in order to manage a PA. How would that work?
Yeah, that lots of emails with them in the last week. Yeah, we have, I mean, our whole team that does all of the claim review and all of the authorizations. We've had quite a bit of conversation about.
So you're saying that you have experts in
Yeah.
that world advising you, you contract with people, or how does that work? I mean, I've been on the other end of PAs, so I know it from the clinician point of view.
Yeah, we have internal experts that review regardless of what it is. We have folks that review.
But this seems fairly specialized, I would imagine. And
Yeah, I mean,
maybe no more so than what else you do.
Yeah.
Okay.
Yeah.
Any other questions? I have one, and I think it's for all of you. Sounds like you guys have had some really great conversations over the last week. I'm wondering, and I know we don't have MVP here, but we have 2 insurers in our QHP market. And I'm wondering if there would be any thoughts on whether you would even need legislation for this, I don't know, or if you would just prefer to do this on your own. I'm wondering if maybe you could come back to us and report back to us, possibly. I'm very serious when I said we are incredibly concerned about affordability. We have done nothing in this committee. I guarantee you, if is about expanding coverage, I have not addressed it, and I have not, and we are very serious about that. I'm wondering if you would be willing to work together with the community to come up with either coverage determinations or whether you would need legislation. I mean, it sounds like it's maybe an issue that insurers should look at. You just mentioned that, the waterproof would cost less than the ambulance trip for somebody who falls. And wondering if maybe work together, we've talked about like limits on physical or like who would need them, maybe ages, number, limiting it to a number of devices so you don't have the my son thing who wants to change everything wanted to change everything every 6 months. If you all would be willing to work together in the next year and then maybe come back to the legislature with recommendations and possible costs.
Yeah, we can do that. And I think to Rep. Tina's question, we can come back with some ranges just for our members of what we see as the potential opportunity or, number of folks. And then we can certainly have some more internal discussion about, to what extent we would ask the committee for support versus what we might just be able to do.
Okay. Is that something you feel as though you need a short bill asking for a report back, or do you think that's something you all can work on your own?
I think we can work on it on our own.
Well, given that we're at the end of the session, or everything is over by nothing, so I wouldn't mind having something that we can say.
Would you like to? Can you say that? Can we write a letter?
Yes, would the committee like to write a letter asking the president VP to work with MVP on this?
The timeframe, yeah, so because, you know, our,
Does Medicaid need to be involved in this or not?
I think we should ask Medicaid to be involved in discussions.
So then maybe it's asking AHS Diva, AHS hyphen Diva, Blue Cross Blue Shield, MVP, and maybe other to work with stakeholders or some general term, like so that then you could include in the discussion advocates or the healthcare advocate or whoever you need to talk with. But something like that, asking, I don't know.
can you help me?
I think I would limit it to Medicaid and our qualified health plans. Probably.
But aren't they going to need to talk to to people? I guess they could just do that without us asking.
And work with interested parties.
Yeah, that's what I meant. Yeah.
Yeah.
Just
Yeah.
saying, asking them to do it, but them to like include
Yes.
stakeholders, so
Yeah.
then they can choose and let people in and, okay.
I just want to understand the distinction between writing a letter and having a short form or a statute in enforceability or holding people accountable to do the work. I don't understand that.
I mean, from a practical standpoint, it would be difficult to enforce the whether if you did it legislatively, difficult to enforce having a conversation if people are not interested in having a conversation. Committees have often written letters asking what seem like willing or interested stakeholders to work together and come back with a proposal or at least explore a topic together. So, I mean, I think, it's less visible in the sense that when there's a letter, it would be posted on your committee webpage, but it wouldn't go into the actual resolves. But it's another option. Sometimes I think the idea of legislation can feel intimidating to parties who are being directed by state law to go have a conversation versus being asked by a committee.
Could we copy the sponsor of the bill on that, on the letter? Just so they know that we're taking action on this.
Right.
I have seen like other committees do this or do memos but it's usually only when there's an agreement like that's been reached on the record on YouTube, like we're hearing here, there's some agreement. So it's a way of like documenting the agreement and without the expense of a bill moving through the legislative process, which takes a lot of time and money. So I actually think if everyone's willing to do it, this is a great compromise.
I think that, and we'll ensure that we talk to MVP as well. But it sounds like this was a conversation that started that Blue Cross was really interested in. Go ahead.
Is it both, we're talking about prosthetics and prosthetics.
I think we would be asking for you all to explore how what coverage would look like, what it could look like, and the cost of it.
Right.
So, what the best
Yeah.
course of action. And then come back with us with recommendations. Sounds great. Karen?
I just want to say the sense of the testimony in your conversations is that for the people who need it, it just makes such a difference in their lives, the quality of their lives, the completeness of their lives. So anyways, thank you for engaging and getting us numbers we could work with.
Appreciate it.
All right. Thank
Thank
you,
you.
Courtney. And thank you so much, Kyle and David, for joining us. I know you weren't on the agenda, but we're so glad that you joined us because you're a wealth of information. Another great emoji.
Our pleasure. Thank you.
Yeah, thank you. All right, so on the agenda, we have next, Jen, you want to come back up? I think we were gonna do budget letter, or we could do it after. I see that, I thought I just saw her, but she's gone.
Mary had to testify.
Oh, okay, so we're gonna do budget letter then. So either,
Tasha for.
oh, yes, And then you can join us when you're ready. Yes.
Mike Fisher, healthcare advocate. I need more information about how co-pays play out. I understand how late and how other states do it. What New England states do. I understand how late it is in your best kind of letter. So if you're gonna say, if you feel like you've had enough and you don't want to hear anything more, I totally understand, but also it's been.
Would you like to sit up here and convey information for just a brief moment? And then we can choose whether or not to ignore you and tell you to go to appropriation. Because Jen already wrote the letter.
I will anyway. Mike Fisher, healthcare advocate. I thought I would share with you that New York has a 50-cent copay for over-the-counter and $1 for genetic and $3 for preferred. Maine has a 0 copay for 90-day mail order and $3 for other. Massachusetts has no copays. And New Hampshire has 0 for under 100% FPL and $4 for over 100% FPL. So in the New England, we would be matched with New Hampshire as having the highest copays. And MABD, FYI, follows the list copay rules, not touched by this. Medicaid copays are banned for pregnancies and kids. And then there's another dynamic that I think is new altogether for you that I think is just worth saying out loud, is to recognize that per HCAR rules, the copay is part of the payment to the pharmacy. And the pharmacy is required, may not deny medical services if the person doesn't have the copay. And so what that means is for some, that doesn't relieve the person of the bill. They still owe the money and the pharmacy can continue to try and collect it. I suppose theoretically could deny services to somebody who owes them money.
Future services.
Yes. The cost of this lands on the Medicaid beneficiary who forks out the money or on the pharmacy in reduced monies to the pharmacy. That's where it actually plays out.
So the person, if they are unable to pay, the pharmacy still must give them the prescription and the pharmacy essentially eats that.
I know those committees had concerns about dinging pharmacies, starting pharmacies. This has that potential, and I don't know, I'm not sure anybody knows to what degree where it actually.
Do we have, well, I'm not sure you would know this, but because you've gotten this great information in just less than 24 hours, I wonder if pharmacies would have any idea of how much they essentially have to write off for uncompensated. Karen, go ahead.
On the budget line item on this, it showed a savings to the state. From what you just said, I'm confused. Would it generate a savings to the state?
I think that there's been some discussion about how the savings to the state, I actually liked the way Nolan said it, reduces the cost of the program and therefore also reduces the Medicaid match for the program. So it has the same effect of the savings to the state are play out according to the match rate, the FMAP match rate. So.
Thank you.
Oh, wow.
Sure.
Just quickly, we heard testimony that the CMS is not going to require people to have a premium. So those ones. Okay, so Massachusetts.
I suppose we'll at some point have to have some.
Okay. And then the other thing you said to me about children not getting, so Dr. Dinosaur has suspended premiums right now.
Right, but we're talking copays at the moment.
Okay.
And that they're or is
Oh,
prohibited.
okay, so they don't have to pay.
Yeah.
Do they? They don't pay now? Didn't know that. Okay, that was what I thought.
Oh, shoot. Thanks, Mike.
Does it have copay?
All right, Jen, yeah, come on up. Okay.
Again, Jen Kirby from the Office of Legislative Counsel. Now I am going to share with you the draft budget letter or memo from this committee to the Appropriations Committee. Starts out with our usual language about your committee appreciating the opportunity to provide your fiscal year 2027, in this case, budget recommendations to House Appropriations. And that you recognize that developing the budget for this year is particularly challenging, and you understand that many difficult decisions went into the governor's recommended budget. As you can accept most of the proposals in the governor's recommended budget as presented, with certain exceptions as described in more detail below. It also recognizes that the committee, I'm going to make this a little bit bigger, received several requests from advocates to fund proposals that were not included in the governor's recommended budget, some of which you strongly encourage the Committee on Appropriations to include in the budget bill. In addition, and here's the copay piece, while the committee is not comfortable with DEVA's proposal in section B307 to increase prescription drug copays from the current $1 for preferred drugs and $3 for non-preferred to $4 for preferred drugs and $8 for non-preferred, if an increase is deemed to be necessary, the committee can support an increase to not more than $2 for preferred drugs and $4 for non-preferred. Says, as in previous years, your committee ranked your recommended funding priorities. Committee members chose their top 5 priorities, which were ranked by weight to arrive at a list of the committee's top 10 priorities. These priorities represent a mix of new proposals from advocates and the committee's request to maintain monies that would be cut in the governor's recommended budget. An additional request, which can be supported with monies available from the Health IT Fund, is described in section A of the language sections following the table. So I put in a table. I am not capable of using Excel, so this is a Word table. And so this was going through in your order of priority, including the tie at 4, which then goes on to 6. Who else pointed it out, but that's how I'm familiar with handling ties. So it's just a brief description of what the proposal is, which agency or department would be affected, the gross amount, the state or general fund amount, and then whether this was in a part of the governor's recommend or a new proposal. So we had the home health, free and referral clinics, SASH, we're still working out exactly which department that agency or department that is. Maintain the AHEC programs, support Vermont Care Partners, the increase to Medicaid rates for the DAs and SSAs, maintain community outreach for Chittenden County, the Bridges to Health transition to the free and referral clinics, Office of the Healthcare Advocate increase, maintain the Team 2 mental health training for first responders, and maintain VSAC education loan repayment. So I tried to indicate when they were in the bill that they were cuts. A couple of just asterisks Nolan asked me to put in, indicating that he has not verified these numbers. He's working on that. And it says, in addition to your requests above, the committee has 4 language requests for inclusion in the budget bill sections. I've just sort of described them and then have the language. Section A would maintain funding to Vermont 211 using monies from the Health IT Fund to enable that resource to establish a closed loop referral pathway with the University of Vermont Health to better connect Vermonters with appropriate healthcare services. Section B would eliminate the 2027 sunset on an existing scholarship program for medical students planning a career in primary care. There's no additional cost to this request, as the statute already allows funds to be carried forward, and $476,770 remains from prior appropriations. Based on the information that's provided to you, removing the sunset would allow approximately 11 more awards to be made to students in fiscal years 27 and 28. Section C expresses legislative intent that the Department of Vermont Health Access figure out how to implement a coding change that would enable the state to receive 90/10 federal matching funds for certain family planning services. And section D would replace language in the governor's recommended budget that requires pursuit of a section 1332 waiver for reinsurance with language from H 585 as introduced with a technical revision. That's when Addie told us that we didn't get to pass through on cost sharing reductions, which would authorize but not require pursuit of the waiver. And then I added the committee does not want to mandate that the state devote time and resources to seeking a waiver if it does not make sense to do so. Then we have the language, which I've made sections A through D. The first is integration of Epic and Vermont 211 for direct closed loop referral pathway, appropriating $332,000 from the Health IT Fund to DMH in fiscal year 27 for a grant to Vermont 211 to establish a closed loop referral system between Vermont 211 and healthcare providers at University of Vermont Health. Section B removes the sunset on 18 VSA section 33, which is the medical students primary care program that is currently scheduled to be repealed on July 1st, 2027.
You have a question?
Yep.
Does that mean it goes on in perpetuity?
It means the program itself does, but the funding, unless the new funding is added, the funding would run out, as I understand it, after
Once
FY 28.
that fund is over, then we decide whether to yeah.
Right, you can always put more money into the fund, but the program would remain on the books. Section C is the DEVA Family Planning Code implementation and a report specifying that it is the intent of the General Assembly that DEVA determine the steps necessary to implement the family planning codes in Vermont Medicaid that are eligible for a 90% federal match, promptly take those steps and deploy the appropriate codes. And honor before, and I just picked a date before you come back, October 1st, 2026, the department would report to the Health Reform Oversight Committee and Joint Fiscal Committee regarding the steps it determined were necessary, whether and how it implemented the codes, and the funding impacts that will need to be reflected in the FY 27 budget adjustment. And then section 7 is the reinsurance language, and this would authorize DEVA in consultation with DFR, authorize them to submit a state innovation waiver pursuant to section 1332 of the Patient Protection and Affordable Care Act as amended by a related act to establish a program for reinsurance and seek federal pass-through funding of amounts attributable to premium tax credits under 26 USC section 36B without the reference to the cost sharing reductions. And that is.
Can I flag, I hate to make changes here, but we really should send appropriations all of the asks that we received. So would it be possible to include a sentence saying, making reference to, we have attached a spreadsheet of all requests that were received here below as our rankings of 1 through 10.
Would it be like an addendum or an appendix or something?
Yes, which
I don't know what it would be called.
It would be an addendum, but I'm not putting that in. I'm just saying we've attached a spreadsheet.
that way they can see everything that we've looked at.
I didn't say appendage, right? It's addendum or appendix.
So I said that I'll put this up, but I don't want to type on live YouTube. I never tell this all. So I just added at the end of this paragraph, on the second paragraph on the first page, the committee has attached a spreadsheet showing all of the funding requests we received, some of which are included in our top 10 priorities below.
And I'll also say that I will go in next Thursday to appropriations to present our budget recommendations, and I will ensure that I offer the information from our healthcare advocate that he just had on the prescription copay. Any questions? Oh, Brian, go ahead.
I have two questions. One is, it looks like by expanding the scope of the prioritization process to 10, we have expressed a broader range of recommendations, which I think is good. Like I'm glad we did that. I'm curious, how much were we able to save and how much not? Like, in other words, like out of those 10 things, we covered a lot. And then the language is like, we found a lot of fixes. What is going to be cut that what remains? Because some of those cuts were things that weren't like a program being cut. It was like, like how they reallocate funding or something is naturally shutting down. And I'm just curious what the casualties were. I know that's like a harsh way to put it. Like what didn't make it?
I think we would have to take that spreadsheet and add
I
up
could just look at it later.
everything,
Yeah.
yeah.
Maybe I'll look at the final product because it will have that attached just to know. Because it would just be good to like acknowledge what those things are. And I'm just curious how much of them were things that it's not really a program cut, but rather like a restructuring. Because some of them were like they're cutting it, but they're not cutting it because something is being cut. They're cutting it because it's no longer needed or it's being done in a different way. And I'm just curious. And the second thing is that this is a letter to appropriations, which is why people really don't want to talk about revenue. I'm curious if we are going to have an opportunity to send a revenue letter to the Ways and Means Committee, because we've never done that before. But like, why, if a committee can't give policy recommendations to the Revenue Committee, but we give it to the Appropriations Committee, it seems like unbalanced. And so it would just be like an idea to take to leadership or whatever, is maybe committees could start having the opportunity to give a revenue letter. I don't know. If they choose.
That's a great idea. Would you like to speak to leadership?
If you designate me to be the one so that I'm not once again this random person asking them to do some radical thing, yes, I will speak to them. But as long as they know I'm doing it as with the blessing of the committee and it's not me once again asking for a meeting to ask them to, create universal health care or something.
I'm
wouldn't say
confused. What revenue are you referring?
Well, for example, like in my objection, I pointed out that the big beautiful bill HR one, not our HR one, but the federal HR one, gave tax cuts to all of us. Yeah, to all of us. But that if we just looked at the top 1%, that's 208 million. The top people over $500,000, 280 million. To top 20%,
So it's revenue, like you're generalizing.
Yeah.
It's not like this committee somehow made cuts that.
No.
State money.
No, it'd be more
Not our
like, imagine if
revenue.
just like every committee is asked to write a letter to appropriations by a certain date every year for them to take into account in the big bill, our big beautiful bill, then that there's a tax bill every year. And we're never asked to give feedback into that. What if we're given a chance and then we could say things like, I'm just making this up. This is not right. We want to eliminate the healthcare provider tax, or we want to create a new tax in the healthcare system, or we want the state to recapture the Trump tax cuts for the highest, or like it gives us as a committee a voice in that bill, which we don't currently have, which I was told we could not put in this letter. And I actually respect that because this is appropriations. So why would we tell appropriations to include a tax? Although sometimes the budget does have tax stuff in it. But
I will say that I will communicate with leadership.
Okay.
I encourage you to communicate with leadership
All right.
and remind you that every single time we do a bill around policy, we make recommendations of the policy as well as how to pay for it, which goes to Ways and
Yeah.
Means. So we do weigh in on, we think you should collect this fee or something like that. Pepper.
I need my memory refreshed. I get down to on the chart. I get down to 6 and I remember all of that. How did 7, 8, 9, 10, how did they get their rankings? Because the last ranking is PSAC and I thought.
Okay, so I gave each member of the committee 5 votes to rank their 5.
Right.
I did not say we were going to send 5 things only to appropriations. We took the 10 top vote getters we ranked them in order of the committee's earnestness about them. And we are submitting, here are the top 10 things of this spreadsheet that we're including of all the asks that we had. These were the ones that rose to the interest and the endorsement of the committee, ranked in order.
Okay, now,
That's how they got up there.
okay, well, I'm still confused.
Okay.
Sorry. How did, so what you're saying, this is when all the numbers were added up, that VSAC, Education Loan Program?
Yeah.
Came in 10th?
They came in 10. That was pretty good. We had 20 some things. How many items
I
were on
thought
that list?
VSAC was higher than that, at least on the piece of paper I had.
AHEC came
2.
at number 4, a tie with Vermont Care Partners.
Daisy sent an email that breaks it up and.
Yes, Daisy sent an email that had the total votes.
I didn't see.
Yeah. Okay,
I can forward it to you if you want.
any concerns, questions? I just want a straw poll on whether or not the committee supports sending this letter and recommendations to our House Committee on Appropriations. Can somebody remind me if somebody is absent for a straw poll, are they able to weigh in I think they're able to weigh in at a later time.
That has been the case in the past.
Oh,
That's what the Lipper used to do.
That day, yeah, I think it was
Yeah, that day. Yeah,
He was told the straw poll vote, but we can't do that one with the roll call.
Daisy was not able to get here at this moment, so I will get her. Okay, so all those in favor of sending this letter and information to appropriations, a show of hands if you approve it. Okay, 10-01, and I will ask Daisy hers. Hopefully we'll have an 11-0. She's the one
We'll send the updated version with that sentence to Tasha, and then I can send it if you want to appropriations. Copy.
that would be fantastic. And I will be there Thursday of next week.
And could I thank you for taking that additional information about the prescription reimbursements to the.
Yes.
Appreciate that.
Could they keep walking in and out and I keep missing? I'm gonna ask our healthcare advocate if he could write all that down for me.
Yeah.
All right, we need to take a break, right?
Yes.
Yeah, let's take a break. Let's be back here. When do we think Mary will be able to be here?
Should be here soon. The previous testimony was scheduled to end at 2:45.
Okay, so let's be back here at 2:50. Okay, and I think we'll have plenty of time before floor. Okay, so 2:50.